The third case is a male patient in his 70s with pancreatic head tumor with cystic lesion in pancreas body. It was found by screening abdominal US. The CAT scan and the MRI confirmed 2 centimeter tumor located in pancreatic head. There are also cystic lesion in the pancreas body to tail. EUS and FNA will be performed by Dr. Thierry Ponchon.
Hello, good morning.
Good morning.
Okay. Good morning, Itami. It's my great pleasure to work here in Toyosu Hospital with Shomei Ryozawa, my colleague. And just to remember you that once I performed a life course, but in Yokohama Showa University, there was a huge earthquake during my demonstration. So I hope this time it will be quiet. Huh? So I have a chance also to work with Jacques Deviere and Gary May, so they will control me. So we are using a GF UCT 260 endoscope from Olympus, and with a small console, a small processor from Olympus for EOS, and this is a linear endoscope. Of course, not a radial endoscope to perform FNA. And the purpose is to perform, in fact, a fine needle biopsy in this case. So now we are in the duodenum, as you can see, but I push the endoscope, and then I will pull the endoscope to be in a better positioning. Okay, like this. And now we can move to the EOS image. And I will pull. You see, I can, of course, I inflate the balloon or deflate the balloon. So I will inflate a little, gently the balloon. Now I try to. Okay, you see just on the right, and this is the portal vein, and you see just on the right, you see the lesion, which appears as a hypoechoic in the pancreatic head. In fact, it's located in the process incinatus.
You see that for looking at the pancreatic head from the duodenum, Thierry is torquing the endoscope to the right.
Yes.
When we pull back from the genu inferius, the head of the pancreas is better visible when you torque the endoscope to the right.
We will freeze in order to measure the lesion. Maybe 1 minute. Yes. Maybe you can measure the lesion. And you see just on the left, on the left side of the screen, you see a small lymph node. So the lesion is 18 millimeter diameter. It's a lesion looking round, and you see a small here. You see a small lymph node here. Okay, just here. And when we twist the endoscope a little more on the right, I need to pull a little more. Okay, here or here, you see we twist the endoscope here, and you see on the right, we see the pancreatic duct, and the pancreatic duct is dilated, and just here, and the pancreatic duct approach the lesions laterally, and that's why it is dilated. You see? Just here. And I think what is interesting for this patient is that, in fact, he has no invasion of portal vein like this. You see, no invasion of a portal vein, and there is still a small part of tissue between normal tissue between the lesion and the portal vein. And so it means that the lesion is resectable.
Yes. Yes.
And the patient looks operable. And we did not see any dilation of a common bile duct. Okay? Okay? So we'll process any question.
Just a comment, we don't have fluoroscopic control, but the position of Thierry is a straight position.
Yes.
Because if you have a long position when you examine the pancreas, you are in trouble when you have to pass the FNA needle, which will change the flexibility of the endoscope. And the straight position is definitively the best one to position the tumor in front of the endoscope.
Except the fact that I'm obliged to have a bending here up. So I need to, when I will insert the needle, I need to be like this, and then I will turn like this. Okay?
Terry?
You see?
Terry, can you hear us?
Yes?
Can you hear us?
Yes?
Okay, so this is a nice lesion, operable, patient is fit for surgery. Is there a need for FNA or FNB?
Maybe
Why
not.
directly, but directly go for surgery? Why should we do an FN?
Maybe not. You're right. But this was also something we could discuss, because the lesion is so obvious. But maybe we don't need to perform FNB, FNA. You're right.
Well, we have to keep in mind that even for resectable patients, there are more and more MDT which decide to send the patient for a neoadjuvant therapy also in many cases. So I agree that this patient could go directly to surgery, but you see that there are several lymph nodes there which are suspicious.
I need to reposition.
And in many cancer centers, they really like to have an FNA or a histological confirmation before.
I will insert now. So what do you think? We should perform FNB, or we let like this?
I would do an FNA for me.
Or FNA or FNB? FNA. So I prefer to position the needle now, because we are now straight. So we have better chance to be in a good positioning. Just I want to, yes.
Thierry, are you doing FNB on all solid lesions, or do you see any role for an FNA in solid masses at all at this point?
No, I think now it has been demonstrated that FNB has a higher accuracy than FNA. So the problem with FNB, it was in the past difficult to manipulate FNB, because the needle were very rigid. But now we have 25 FNB, and the flexibility is more or less the same than 22 gauge FNA. And I'm using both Procore from Cook and Acquire from Boston. So I think definitively now FNB is the gold standard. Okay. So we need to have X-ray again, EUS again. So I twist, yes, I inflate. So we go back. You will see the lesion on the right. Yes, now it appears. Okay. So I try to be as straight as possible. I have a feeling I was a little better positioned before. But you see the lesion is really in the process in synetes here. Nevertheless, it's not so bad, no? It's okay. It looks nice.
Yes.
So you can hold the endoscope a little once. Yes, you can hold the endoscope.
Okay.
So the purpose here is to have the lesion in a good position for the axis of the needle, and to avoid to pass through too much of the normal parenchyma of the pancreas also.
Yes, but we are obliged to pass a little through normal parenchyma. Huh? You hold the endoscope like this?
Okay.
Thank you. Hold like this. Okay. A little more. Pull. Yes. Yes, now it's not bad. I approach the needle. You see the needle at the upper part of.
谷坂先生、ちょっとあれだったらコントロールしてね。違うスコープじゃなくて。とか。
You see the needle?
矢印で示せる？
So this is the needle in the lesion, not exactly in the middle, but the positioning is not so easy always in process in synetus. So as it is a procore, I should push, and then I will pull. So you can remove we will use, I will try to perform fanning method, so to change the direction of the needle, and at the same time, we'll pull slowly the stylet out. This is slow pull technique, okay? So you take it, okay, take it. Slowly, 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 slowly. Change the positioning. You have to turn like turn like this. Okay.
Okay.
Okay. Yes. The problem is that I'm not totally happy because I could not succeed to change the position. No? You see, maybe yes. Yes, pull a little more. Yes, pull a little more. Okay, like this. Okay. Now it's better. Continue to pull. Yes, pull. Can pull. Yes, yes, like
So
this.
this fanning technique is done using the elevator of the endoscope and torquing the scope.
Yes,
huh?
but you see now I'm out. Huh?
Now you are out, so you should start again, but
Don't.
take the sample that you have now.
I think so. So you can we take it out and we will see what we have already. Yes. We went out easily because this is the process in sinuses, so it's not so easy to stay in place.
Yes.
But you see, the lesion is now maybe it's the location is a little better. But as soon as you insert the needle is nevertheless a little rigid, and then you are missing the position. So
We want to show the
yes,
specimen.
yes, please do it because this is the principle. Here we have blood only. And the core looks usually no, we need to do it again, huh? Because I see only blood.
Yeah.
Push some air, yes. We need to do it again. In fact, you can still see the lesions on the right, but I decided to stop to perform FNB for two reasons. First reason, it's little bleeding, but does not matter too much. But the second reason is that when I attempt to perform a second FNB, I observe that when I push the needle, you see too much pancreatic tissue in between the needle and the lesion. So in fact, we are taking risk, and at the end, the patient, in any case, the patient will have surgery. So I don't think FNB is really mandatory. Even if an FNB is negative, we will perform surgery. So for safety reason, I think because the problem is only mainly to induce an hematoma, and then surgery will become more difficult if we have an hematoma. So you see that in any case, I'm obliged to pass through normal pancreatic tissue in between the probe and the tumor. So I think we don't need to take more risk in this case.
Yeah, I agree. I think that it's the principle that Jacques mentioned this morning with ERCP. You have to put the whole case into perspective, and in this situation, it's unlikely this is anything else.
Yes.
He's a surgical candidate, and the last thing we want to do is induce a complication
Yes.
that'll make surgery more difficult for him.
You see, in this case, we are in a good position to make the puncture, yes. But when we push the needle, we pass through at least 1 centimeter or 1 centimeter and a half of normal tissue. And so I don't see and with some vessels, as you can see. So I don't see the role of performing, taking risk, and especially because in this case, the lesion is small, huh? And less than 20 millimeter, and with no invasion of a portal vein. So it's an excellent case for resection. So it could be, you see, and so it's better to at least that we have the picture are sufficient, and furthermore we have an excellent staging, and there is only one lymph node. Okay. Okay.
No,
So I prefer it's better to be safe.
And
Oh, we will also analyze the first pass, but
Absolutely.
okay, we'll see.
on the gross, it didn't appear that there was much tissue, which we suspected by looking at it. But the uncinate process is a difficult place in the pancreas. They can be very difficult to access.
Okay, so thank you.
Thank you.
Thank you very much. Thank you. We're moving back to Dr. Yahagi Sensei. Thank you very much.
You're welcome.
Thierry.